Well, hello and welcome to the CSF monthly podcast for September. And this month I'm going to review two papers that we've uploaded onto the CSF website. Now remember, the detailed slide set for these papers can be found on the website. They're succinct, they are interpreted in such a way as to be, I hope, useful to you, but also potentially useful to audiences that you may be addressing with this information. Now the first paper I want to highlight compares the in vitro cellular pharmacology of baricitinib, tofacitinib and upadacitinib across relevant leukocyte subpopulations, and also compares that to their potential in vivo pharmacokinetics. It's actually a paper that I wrote along with my colleague Peter Taylor and others. Peter's based in the University of Oxford. Now, in this study, we were looking at several JAK inhibitors which have been shown to be efficacious in the treatment of rheumatoid arthritis and indeed in some other autoimmune diseases in earlier clinical trials. And we looked at baricitinib and tofacitinib, both of them are approved, as well as upadacitinib, which is still in clinical development but is very close to approval, and we are expecting that to be available quite widely in due course. And the objective of this study was really to look using an in vitro system at the pharmacology of these three agents across relevant leukocyte subpopulations. And we brought in some information that we know about from their in vivo pharmacology to allow us to examine the effects of these medicines on distinct cytokine pathways. We use peripheral blood mononuclear cells from healthy donors as the target cells. So we're not inferring how the drug works in any individual disease state here. These were, if you like, healthy cells used simply to inform the JAK inhibition pathways. And the choice of cytokine concentrations and incubation conditions that we used had been optimized in order to ensure a consistent signaling pathway in different cell types. We used especially phosphorylated signal transducer and activator of transcription phosphostat signals, and that was all previously optimized before we put the dose concentrations on. And we're interested in levels of phosphostat measured following cytokine stimulation, and we looked at the IC50 values. That is the dose of drug required to inhibit by 50% the signal promoted by any one individual cytokine. And we did this in phenotypically gated leukocyte subpopulations. The time above the IC50 of the individual drugs and average daily percentage inhibition of phosphostat formation was calculated for each JAK inhibitor, cytokine, and cell type. So when we looked in vitro, the results were as follows. Well, first of all, we were able to show potent inhibition of JAK1 and JAK3 dependent cytokines, and that's IL-2, IL-4, IL-15, and IL-21, and tofacitinib, as expected, baricitinib to some extent, and also upadacitinib, probably as expected through its JAK1 selectivity, were all effective in that assay. Similarly, baricitinib and to some extent tofacitinib were effective inhibiting JAK2 signaling cytokines, for example, IL-3, GM-CSF, and also at higher doses, upadacitinib had some inhibitory activity here, and that suggests that at least at higher doses, it may be predominantly JAK1 selective, but have some effect on JAK2. All of the JAK inhibitors when we looked across the board, had the capacity to inhibit JAK1-dependent signaling, and as I say, the differences tended to rise more in JAK2 and JAK3, sometimes touching even TYK2-dependent signals, although we're not suggesting on the basis of that TYK2 was specifically targeted by these agents. So what are the key implications here? Well, we're at a stage in the use of JAK inhibitors where we're starting to imagine that different JAK selectivity may confer different safety profiles in these agents. Certainly the efficacy profile looks pretty good right across the class at the moment, but we are interested now in whether we can distinguish, for example, is a highly JAK1 selective picture, is that preferable to being more of a pan-JAK inhibitor? Now this study doesn't answer that question in entirety, but what it does do is it allows us to demonstrate using whole cell assays, which are probably the most representative of what is happening in patients, that there is a degree of selectivity, that these drugs are not identical, but that at least at higher doses they do begin to pick up so-called off-target effects. So JAK2, for upadacitinib, even though its predominant effect is in JAK1 at its most likely therapeutic inhibitory dose. Now that matters when we start to think in future potentially about dose ranging, and it may also be in patients who have variable pharmacokinetics, for example, altered metabolism of these agents. That may lead to some differences in the way in which the actual JAK inhibitors will exhibit selectivity in vivo. So more work to be done in this area. This is just very provisional. I suggest you file this away and think about it. And in due course, we will see far larger safety data sets that really tell us whether there's a meaningful difference when we compare these different agents. Now, the second paper I want to highlight compares the clinical outcomes of withdrawal dose reduction and continuation of tofacitinib in people with rheumatoid arthritis achieving remission or low disease activity state. And the first author here is Dr. Mori from Kumamoto in Japan. Now, maintaining a state of remission or low disease activity is obviously beneficial for people with rheumatoid. But the potential, of course, of continuing medicines is that you have to pay for them, so there are costs associated with that, and also the potential for adverse events. And there's certainly a vogue nowadays for us to look at whether we can withdraw or at least taper medicines in that clinical scenario. So this was a long-term prospective study, and it compared the clinical outcomes of withdrawal dose reduction and or continuation of tofacitinib, people with rheumatoid arthritis achieving remission or LDA through an initial year-long induction therapeutic phase. And they also looked at the effectiveness of reintroducing tofacitinib therapy upon flare of disease, because obviously that's the question the patient's going to ask. Well, I can stop, see what happens. What happens if I then just go back onto the medicine? Will everything be okay? Participants received induction therapy with tofacitinib 5 milligrams BID for 1 year. A bit long, really, for an induction regime, but you get the idea that this was the phase where all patients had to receive active therapy. And those maintaining remission at the end of this phase were assigned to either withdrawal, dose reduction to 5 milligrams tofacitinib once a day, or simply continuation of the BID dosing. Patients in all groups received periodic follow-up to assess disease activity using a monthly CDI, and patients experiencing disease flare during follow-up started rescue therapy by returning to the original regimen, so restarting tofacitinib in the withdrawal group or going back to 5 milligrams BID in the group in whom the dose had simply been reduced. So what are the key results? Well, 68 patients from the 100 enrolled achieved remission or low disease activity during the first year. That's about the number we would expect. Remember, there's no control placebo arm here, so you're seeing a real-life experience. The crude incidence rate per patient year with 95% confidence intervals of disease flare was higher in the withdrawal group. It was 0.73, followed by dose reduction, 0.44, and the continuation group, 0.04. The withdrawal group also had the lowest median time of flare-free survival at 7 months, compared to 21 months for dose reduction. The adjusted hazard ratios with 95% confidence intervals was similarly higher for withdrawal at 18.11 and lower for the dose reduction at 9.13 compared with continuation. Now, all patients except one regained disease control within 1 month of reintroduction of tofacitinib at the first year dose when they had their flare during that withdrawal or dose reduction period. Well, so this is a really interesting study. What do we infer? Well, the rapid and continued disease control in over 1 year of tofacitinib treatment following dose reduction strategy is a more preferable than an immediate withdrawal strategy. I think that's probably what we would expect. In general, with biologic medicines, we found that tapering of dose rather than cessation of dose has been preferable. It does look as if we need to keep medicines on board for at least part of the residual disease presence. Remission is not absence of initiators of disease, in other words. Patients that experienced disease flares, however, in this study did regain control when they restarted their original drug regimen. So if a patient comes to you and says, look, I'd like to try a period of time without my medicine, I'm doing really well, you can at least give them that option if they're keen, but you have the reassurance that they're highly likely to regain control in the event that they flare. Well, that's all I've got for you this month. Remember, everything that I've talked about is available in this detailed slide format in the publications section of cytokinesignaling.com. You can have a look at that. I hope you find it useful. The slides I find especially useful. They really are. They're very clear and very valuable, both for self-education, but also if I'm wanting to talk to other people about these data. And don't forget to subscribe to our podcast, either on our website, SoundCloud, YouTube, or Apple Podcast. And please do let us know what you think by leaving a review. And meantime, thanks ever so much for listening. I hope you'll find this useful to you in your clinical practice. And I look forward to talking to you in another podcast from cytokinesignaling.com.